guts of this model a little bit to show you what it's all about, and then show the extensions of that in the work that we're doing. This is extremely a work in progress. I'm in the discovery stage for most things at this point. So I'm at the point where I'm being surprised by things that I can't understand. I'm pretty sure most of them are my mistakes, but it is, so I'm opening up the pickle vat, so to speak. Jump in anytime, anyone with questions, thoughts, comments, or suggestions about things we might want to think about. So this is the model that we published, which is basically an SIR model, but with some, which I'll show you in a little bit. And it just says, well, we can go through and do nothing, and we can see a lot of cases, or we can put in a quarantine for a while, or do some additional testing, so like go to effective quarantine. It brings you up. I'm just going to need to figure out how to do thumbnail video so I can see my screen. And it says, oh, we've got some quarantine. If the quarantine becomes more effective, what happens? Oh, it gets worse. Why is that? Because we've taken the population, we stopped them from getting the disease, and then we lifted the quarantine and everybody gets it. So you can actually find a perfect effectiveness for the quarantine. You can make it shorter, things get worse, you can make it longer, and then you can actually make the quarantine a little less effective or a little more effective and play around with that. It gives people a chance to kind of muck around with things. The reason I put this up was because I saw a lot of things out there, and all of them are based on this huge variety of assumptions, but nobody lets you really play with those assumptions. So we put all the disease assumptions in there. Severity spread says you're going to get the disease, what kind of severity you're going to get it with. Infectivity, in this model, it's actually, it doesn't matter, 0.45% is the thing the epidemiologists are coming up with. This is actually 40%, but contact rate is a tiny number. So anyway, those two kind of cancel each other. Behavioral assumptions on the contact rate, 1 versus 185 is what I'm using these days. Mildly symptomatic adjustment, like how do you change yourself if you have, feel like you have a cold or flu or something. If you're symptomatic, how do you change your behavior? And if you're tested positive for COVID-19, how do you change your behavior? And then duration assumption. So there's a infectious, not contagious stage, 2 days, a contagious but not symptomatic stage of 4 days here, symptomatic and contagious, and that's by severity. So the mild and medium and asymptomatic are shorter, the moderate and severe are longer. Severe, by the way, means that you will require hospitalization. It's kind of the terminology that's been used. And then after, you can stay symptomatic, but end up no longer being contagious at the tail end of it. And then there are mortality assumptions. These were pretty simple. 0.1% of the moderate people die, and 15%, 1.15. It's a huge number. I don't know where that came from. That was a big number. So make that a smaller number and fewer people will die. So that's all cool, because it doesn't really matter in this model what you do there, because the model itself is, this is, how many people recognize this as a standard SIR model? So I'm going to zoom in a little bit. It's probably not legible. This is the advantage of everyone being on a screen. It's more like you can actually see what I'm sending. And by the way, please, if I'm going too fast or saying things that don't make sense, feel free to jump in.
Bob, you're not sharing your screen. We can't see your screen.
What?
Are you sharing your screen?
It says I'm sharing my screen. Because nobody see my screen?
I can see it.
We can see.
See it too.
Okay, Rafat, it's your problem apparently.
Yes. Okay, I figured it out. Thank you.
All right, fabulous. So we have an uninfected at risk pool, which is the standard SIR thing. And then instead of having a simple infected category, I've got a bunch of stages of infected. So there's not contagious when you just first get it, but you're already kind of moving along. There's asymptomatic but contagious, symptomatic and contagious, and then symptomatic but no longer contagious. And finally, this doesn't quite all fit on a single thing. Get rid of results here. I can open this up. finally you go back and you end up being recovered. So the kick in COVID-19, of course, is you can be tested for whether or not you have it. So for each of these stages of progression along here, you can go through testing, and if you go through testing, you end up in exactly the same chain, but of people who are tested. And the tested progression is the same, but the behavioral assumptions that I just pointed to are different for that set of people. And you can die from either of the groups for the moderate and severe conditions. The moderate death rate is very, very low. The severe one is quite high, and that's where the deaths come from. And so that's actually the extent of the model. There's a bunch of, well, there's the infection contact part, which has got all the different groups of people. So they're asymptomatic, not tested, but they're contagious. They're symptomatic, they're not tested, but they're contagious. These people are, this is the universe of people who have the disease, could give you the disease, but no, they haven't. These are people who have some symptoms, and they are contagious. And these are people who are tested. They may or may not have symptoms, and they are contagious. And they all have different behavioral associated with them. There's a global contact rate. Go ahead.
One question. The
Yes.
shocks are arrays, and so are the flows. So what
They're arrayed by the severity condition. So we have 4 different severities. Open up the array editor. Severity is asymptomatic, so you actually show no symptoms, mild, moderate, and severe. And severe is the one that needs hospitalization. And so the arrays here are all by that, and what your type you is determined up front by this infectivity spread. So we preordain that, although in a sense it's a metaphysical issue whether we preordain it or not. You don't evolve into these different categories. You will evolve into them because you set them at the very beginning. So everybody actually stays in the same chain they start with in terms of severity. So that's where the arrays come from.
Thank you.
And so, yes.
Quick, this is Fred. Where does the incubation period enter the model?
So because this is conveyors, they all show up. Oops, back to X in the conveyance time.
Okay.
Days infected, symptomatic. Days contagious, not asymptomatic. Days symptomatic. This one's actually arrayed, and the actual numbers are down here in various places. But because it's because we're using the conveyors, they don't show up as a connector into it. They just show up inside of the conveyor.
Okay. Some of the data I've seen suggests around up to a 2-week incubation period for some people, and from symptom appearance to death, that can be on the order of like 3 weeks, maybe. In some people,
it can be. There's quite a bit of spread, and actually I'll get to that a little bit later, because the next kind of major, I guess the next, I just changed the order, but I didn't tell you what order I was going to go in, so you won't know that. The next major topic I'm going to go to is perfect mixing versus using the conveyors, kind of showing the difference between those two.
Okay.
And then from that, we'll go and take a look at, in that perfect mixing model, we're going to look at distributions of times. So I will get there. I will get there soon. In this one, it's pure conveyor, and there's just these fixed times. And since it's a conveyor, that means whoever comes in after exactly that length of time, they come out the other end. So contacts is then determined by all these different people's assumptions, and then there's a global intervention, which has some effectiveness, which causes the global contact rate to go down. That gives you all of those come together to determine contacts, and then the contacts, typical SIR stuff, fast diffusion stuff, is with the at-risk, based upon the total population and the population at risk, and that determines how many infections come into the system. And then the other thing worth talking about is just the testing process. A little bit involved, but not super complicated. So there's a testing rate for symptomatic people, which is fairly straightforward, except if you don't have enough tests to go around, they don't actually end up getting tested, but they get first priority for testing. If you have sufficient capacity, you can also test asymptomatic people, and there's a contacts tested per positive tests. It's kind of a efficiency of actually executing a test, which is kind of meant to replicate contact tracing that would be used in testing when you get a positive to trace the contacts and either test, and well, in this case, test those people. What's actually happening is they're isolating those people, as I understand it, but that's where that's coming from. So it's enough fidelity in here to look at the different kinds of assumptions that are typically being made in models, and a little bit more fidelity around the internal dynamics than is usually presented in the models. Most of the models in use are really standard SIR models with perfect mixing and just the uninfected, infected, and recovered. Although there's some more, there tends to be a little bit more around disease progression to determine deaths in those models. Okay, that all makes sense to everyone? All right. So the next topic I want to jump to is, and by the way, I have a hard stop at 3 o'clock because I'm going to call, so just forewarning, is this concept of modeling COVID-19 effectively, and that is the question: what's the difference between perfect mixing and not perfect mixing? So the perfect mixing is what we're used to in this, and I'll show you the model behind this, but first I'll kind of show you how it behaves. This is actually published in the wrong place. And it says this model on top has the structure that I just outlined. The model on the bottom has the same structure, but instead of using conveyors, it's using just pair stocks with a the transit time becomes the delay time of the outbound from the stock. And you can see there's a difference in intensity with the same set of parameters. And this is a little bit not completely comparable because you might want to make adjustments to the parameters of it. But the interesting thing is doing something like increasing the quarantine effectiveness. This thing is running, it is good. Oh, I've got a 7-day quarantine, so it didn't do much. So let me give a 60-day quarantine. Increasing the quarantine effectiveness, we can see that with perfect mixing, what it basically does is it pushes everything to one side. Without perfect mixing, we actually get a pretty significant change in behavior up front. And the point I was trying to make was that if you assume perfect mixing, and this isn't even perfect mixing like assuming only 3 stocks, this is perfect mixing assuming you still have a cascaded set of flows like an aging chain. You end up getting very substantially different results under the same set of assumptions. And I'm a little bit worried that we're using far too simplistic models in trying to understand, kind of looking forward, what we should be expecting in terms of infections and uptake, which is where this came from. So what I want to do is actually jump to this model, which I'm going to have to do in a different version of Stella because it's using a feature that's not yet available. So this is Stella 2.0. I'm not going to show you the cool 2.0 stuff just now, but I have COVID-19. This one. So this is the structure of the model we were just looking at a minute ago, with the conveyors for everyone doing everything. And this is the same model with the same thing, but instead of conveyors, we're using the conveyance times, which are brought in as ghosts for each of the things. So using the standard formula, the stock divided by the conveyance time. So it's not called conveyance time, it's called time delay in that case, the stock divided by the mean residence time for each of the stocks. So that's the only difference. This thing still has this full cascaded structure and everything going on. Contacts is all the same formulation. Testing is all the same formulation. The only difference is we're using the, the Euler distribution of outcomes here instead of a pure delay, which is a peak thing. And actually, in this real model, you were getting at, Fred, inside of conveyors, what we're doing is using what's called a distribution profile as an input. And a distribution profile allows you, instead of saying we're going to get everything at a point, you can specify the distribution in case it's this distribution. And that says that nobody's going to come out right away. So this is like becoming contagious. Nobody's going to become contagious instantly, but they're going to become contagious after a little bit of time. And most likely it'll become somewhere in here, but some people may take quite a bit longer to become contagious. And then the same thing for symptomatic. I think I used the same profile because I was trying to find, even for the flu, this kind of profile, and it's actually kind of difficult to come across. But we know it is not this, which is what we would get with perfect mixing, and we know it is not this.
I think some of the flu modeling suggests that that's 2 to 3 days for.
Well, the duration, yeah, but the spread of the duration, the actual probability distribution of that duration is not something I could find anything on.
Right.
I didn't look deeply. So if I had looked deeply, I would have. But anyway, the pure conveyor thing kind of looks like this. It's a little bit hard to draw it because it just wanted to come back to 0. But you just get a spike at the mean time. And then for this particular model, the way I did I hope that's true, parametric profile for that. That's the profile for distribution these times, transit time asymmetric, asymptomatic. Are these funny things where you take the days contagious and not symptomatic, that's kind of the assumption parameter, and then you divide by a mean value of a probability density function in order to get the thing to give you the same mean output time as you would get otherwise. That may be a little bit confusing. But what happens here is instead of getting pure conveyors, and actually I can show you this same thing with a much simpler model. Should probably make it clear. This is probably, given our audience, the better solution to this. So this is a standard. You have something coming in and something coming out. That thing coming in is using a pulse, so there's just one of them at one time. And then if we go and see how it goes in, the standard for a conveyor would be right at the beginning. And if I ran this model won't run because why? This model run. Profile delay.
You're not using the profile in the equation.
Yeah. This won't run because I changed the software. That was my own fault. But anyway, if I run this model, I just get a spike after the delay time, boom, and it's gone. So if I go and instead of that, I use this, and I'll just undo because it's easier than actually figuring it out. It's like undo is not working, so that's a good thing to know. So there's a profile delay here, which is just called profile. And what happens if we look at profile, it's a funny thing because I want to see what it looks like. But now when we get something coming in, instead of coming out like in one spike, it comes out this way. And if we were to compare that with, actually that stock doesn't do it, but if we were to put it in a profile that looked like this, which one is it? This guy. Probably make it a little bit steeper. No, it doesn't matter. And run it, we would get what you're used to if you see a pulse into a smooth, just a standard smooth function. So this profile then allows you to kind of do a distribution any way you want it. And so in terms of realism in modeling the disease spread, it gives you a lot more control over the incoming things because it says that, it's going to have a mean of 4 days in this case, but it's going to be distributed anywhere from probably like a day to 6 or 7 days. There'll be a distribution in there. And so you get a more accurate representation of things coming into this chain. Okay, that was a really long-winded answer to your question, Fred.
That's a good one, though. Thank you.
But that's where that stuff is going to. And the whole point of this this simulator is just to say that if we're making perfect mixing assumptions and we're actually basing expectations on them, it's probably not going to be very accurate because they behave differently than you know, the number of things where people actually have to go through the various symptomatic stages and come out. Okay, so that's the, go ahead.
Would it be safe to say the conveyor result is closer to what you might expect from an agent model?
I was overly ambitious and I was going to do a perfect mixing, a conveyor result, no perfect mixing with the smooth inputs, and then also a single stock SIR model. I could compare all four, but I ran out of time. So yes, it is closer to the conveyor, certainly in terms of behavior, but it's between the two, so to speak. So as I say, if you look at the shape, the effective assumption on shape, if you're doing perfect mixing, let me already have closed it, is the Erlang negative exponential. And that is clearly not the distribution of someone who's getting sick. So,
Bob?
Yes.
Who else uses perfect mixing? Is it just a system dynamics thing, or are other modelers that use SIR models also using that kind of assumption?
It's the standard epidemiology. So the epidemiologists the epidemiologists, as far as I can tell, are almost all using differential equations, which is just perfect mixing. And so there is some agent-based work being done, but most of the stuff that I've seen of late has all been based on just real standard SIR models done out as differential equations, often in R. And so, yeah, lots of people are using perfect mixing.
And the difference there is that if we believe that there's a heterogeneity, that the population is different in different subgroups, that mixing isn't a good assumption. That's why you're saying that agent-based models are an alternative. Is that a correct statement?
So I don't know of any agent-based models, well, certainly not for COVID-19, that are looking at heterogeneity in population. It's just that it's realizations of a draw from a distribution for how long you're going to be in any one of the states. And if there is a real distribution there, you have to have that realization manifest in an agent-based model for every individual differently. So first person who gets connected will pick up the virus, presumably in an agent-based model. The way even a contact works is nothing happens. There's a probability that anything will happen. And then if something does happen, there's a distribution duration, how long that individual will be in the state of having the virus multiply before it starts, any viral shedding starts. And I'm assuming they're this smart, but they may not be. They may be using a single number as well for this when I think about it. And then once they've, the viral shedding has started and they start becoming asymptomatic, there's probably another stage, or if you're doing agent-based, you could just have them go through the entire course over some distribution.
Perfect. That answers my question. Thanks a lot.
All right. So that's kind of the difference between perfect mixing and something that's a somewhat more realistic representation of what is happening. And I'd like to be able to make that point that it's important to think about these things probably a little bit more precisely, I guess is the correct word for it, with a little bit more precision than people usually do. Because it does make a difference to the kind of results you'll see manifesting. Now, given that, I have to say there's so much uncertainty around things like what effect the quarantine is having, and actually I'm going to kind of get to this, the changes in behavior, social distancing and stuff are having, that uncertainty may swamp this uncertainty. So that's the next thing I kind of want to get to, and I'm going to really go more into the modeling side.
Bob, there are some questions in the chat.
Yes.
I'm not paying any attention to that, so if you could read them, that would be wonderful.
Yes, sorry.
I have trouble jumping in and people just kept talking and talking, so thank you. So this was from a while ago, actually. Do we have any data on when contagious status ends? And are there symptomatic, still coughing, non-contagious people?
So and I have to, I'm going to tell you what I think I know, or actually I'm going to tell you what I know, well, I'm going to tell you what I think I know. I guess that's really the best way of phrasing it. So viral shedding can persist for up to 30 days. There is no clinical work to show whether or not that a person who is still shedding viruses at that stage is contagious or not. What happens is the viral shedding is very heavily front-loaded. So early on in the infection process, you're very infectious. And then as the disease progresses, you become less infectious over time. But the viral shedding does not actually stop until a very long time. And unfortunately, this is one of the reasons I started this modeling, is I kept looking at stuff and realizing that we know very little about the way this virus actually works in the human population. And we've had, this was before we had 100,000 people. I was astonished that we knew so little. And now we still know so little, I'm afraid, because what's happening, of course, is the people who are dealing with it are in crisis mode. And it's not exactly something you can sit back and study. So it's a really tough situation. So the answer is, yeah, we kind of know it, but we're really not sure what it means.
And is the R0 parameter specified somewhere or inferred from the contact variable?
So R0 in this kind of model is the product of the contact rate and the infectivity. And so in the first version we were looking at, I think that was 100 times 4. So it was actually an R0 of 4, it would have been at the very early onset. But it's not, so yeah, it's there, but it's there as the way we're talking about it.
Is there a place? Oh.
I have a question from these two graphs are very interesting. So there is a perfect mixing assumption which implies the model without in which the stocks are not conveyors, right?
Right. Yes.
And the perfect mixing model assumes stocks are conveyors.
The perfect mixing model, the stocks are not conveyors. The perfect mixing model, they are conveyors, but this is the model that actually uses that distribution on the input side.
Yep.
So they're not, they don't act like a pure conveyor. They act like a conveyor where people are selectively dumped onto places in the conveyor based on a distribution.
Okay. So it's saying that when there is perfect mixing, there's going to be a big peak, which
careful. What it's actually saying is that the assumption of perfect mixing says that your infection, your R0 effectively, is going to get so small that there's not going to be much anything in the way of an epidemic early on. And then as soon as you release the quarantine, it's just going to go back to the thing it would have done in the first place. If you have no perfect mixing, what it's saying is you're going to get some infections early on. They're going to be contained somewhat. And when you lift the quarantine, that's the quarantine being lifted. But at that point, you have enough people who've already recovered that it doesn't have much of an impact and it kind of dies out as an infection.
So do we know what's the reality? Is there perfect mixing? So the quarantine creates non-perfect mixing. And if there were no quarantine, there'd be perfect mixing?
No, there is no perfect. So perfect mixing is about an individual who enters into a particular stage of infectivity. And perfect mixing assumes that individual is indistinguishable from everyone else who's already been there, whether they've been there for a day or a week. The non-perfect mixing says, oh, they're going to go in there, but we're going to distinguish everybody by which day they arrived.
I see. So when there is non-perfect mixing, which can be facilitated, let's say, by some quarantine regime.
No, the perfect mixing is a characteristic of the way they're representing the system, not of the system itself.
No, I'm talking about non-perfect mixing.
Right, but that's a characteristic. Non-perfect mixing is how we model things. It's not about the system.
I see. It's
The way we represent the system.
whether you use conveyors or you use simple regular stocks.
Right.
I see. But there is an implicit assumption somewhere in these two types of representations. So in reality, for the case of infection, should the stocks be viewed as conveyors, or should the stocks be viewed?
So this no perfect mixing assumption, this one with the distribution of duration over a probability, is actually a very accurate representation of what's happening with respect to the disease onset and progression.
I see. And perfect mixing.
It is the most, that is the most accurate representation you can get using a container, a model that's built up of individual stocks rather than individuals.
I see. This no perfect mixing, and it
yes, no perfect mixing is almost perfect.
it implies using conveyors in stocks.
Well, the only way to do it in Vensim, there's a thing called the delay profile, I think it's called. Yeah, maybe called something different than that. In Stella, it would have to be done using conveyors and this new functionality that we just put in.
I see. Okay.
Yeah, Howard, it's a new feature that lets you define the distribution of where things go into the conveyor. It's not a straight conveyor.
Okay. All right.
So would that structure look the same if the conveyor was broken into a series of co-flows with a stream for each category?
So where's this model? This is delay. This one that actually uses these things. No. Sorry, I have too many models open. I don't know which is which. And I'll call the model, which is not very helpful. Asymptomatic. So this thing is using now. So this is not the right model. Okay, I'm just trying to answer the question and not search for the model. You could do the same thing by having arraying the conveyors one level deeper and having a different conveyance time for each element in that array.
Mm-hmm.
And then having all of those come out and go into the next array and sequence, and also having the same sort of thing. It would be pretty clumsy though, because you'd have to
Right.
the array by so many different elements. But what we're saying is one person comes in and they might be in for 3 days, another person comes in and they might be in for 2 days, and that's all happening. And if like the 100 people come in, there's a distribution of how long they're going to actually be in that conveyor. But once they get on the conveyor, they just move along FIFO like everybody else in the conveyor does. They don't mix after that. They're only mixed when you first put them onto the conveyor. And we just put some ahead of others.
Have you tried to examine the model for what's happening in different countries? China, Italy, India, United States?
That's what I'm kind of getting to next. So what I want to get to next is the model. Oh boy, I'm going to actually exit Stella because I can't figure out where I am anymore. No, I don't want to do that. This is the model I want. Okay, so this is the model I want. I can talk to that question. All right, so this is a model that starts with the it starts with the same epidemiological structure that we were looking at before, where you go through different sets of activities, but it has, in addition to it, some other sectors. So deaths, rather than being a straight death rate coming off of this, there's actually a healthcare response sector in which people who are sick can come into a hospital. There's a non-critical inpatient activity. In the hospital, they can come through, they can end up with an ICU or on ventilation. You're constrained by capacity in the hospital, by the number of people that are available for the hospital. I'll get to those in a second. And in terms of the ICU, you're constrained by the number of ICU beds and also by the number of ventilators available to handle this. Now, the stark reality is if you're in the hospital with COVID-19 and you need a ventilator, you either get a ventilator and you have a 60% chance of surviving, or you don't get a ventilator and you die, which is why ventilators are a real big thing right now, because it's bad. But in addition to that, if there are lots of people who want to come into the hospital, you may not be able to fit them in the hospital, and there's sort of a waiting list over here. And the waiting list is people who aren't able to make it into the hospital, and this has a simpler and much less, this actually is pretty well determined in terms of data on what's happening in hospital systems. This over here is not so much so. So these are the people who don't make it into the hospital. In Italy, if you're over 70 and you have COVID-19, you're home, take your chances, I understand it right now. And though those people either get admitted, or they die while they're waiting, or they manage to recover while they're waiting without any intervention through the hospital. And so the deaths in this model are then driven in completely by this structure. Actually, there's a small amount of death occurring otherwise, because it's just unrealistic. Say people never die in other conditions, but the vast majority of the deaths are here. And the capacity is determined, as I say, by just the number of beds, the physical capacity, but also by the healthcare workers who are going through the same process that any other individual is, potentially getting sick. And the trouble is, of course, they have a higher contact rate than the others. So there's a contact multiplier for healthcare workers, which will cause them to progress this chain a little bit more quickly than the normal population would. And at some point, as reached in this particular model, you may end up where you can't actually have enough healthcare workers to keep the facility properly active, and that will constrain the number of people coming in to the system. And then this model has some PARMs that are import values. Actually, I'm not importing them yet, but things like hospital capacity, population of the country, ventilator capacity, and whatnot. And then it has some calibration stuff, which is parameters that we're potentially using to calibrate over. And it has outcome stuff. And right now, the only outcome stuff I have are deaths and new cases. This is for the US currently. It's kind of interesting. As I say, I'm in very early stages at this. I'm in what I would call the discovery mode, which is that I'm doing stuff and saying that doesn't make any sense. So if I run an optimization in this model and it's already optimized, this will be very fast. So I claimed, right? I thought it was already optimized. Yeah, it's false precision.
So while we're waiting for that, there are a bunch of questions actually.
I'm sorry. Yes, I'm very sorry. You were reading questions and I just got carried away.
It's okay. Is there a place to adjust the test sensitivity or specificity?
Specificity. So in that particular model, the tests were assumed to be perfect. But yeah, that is definitely true, that the tests often come back with both false positives and false negatives. And so we haven't put that into the model yet, but that should be there.
And do you have a means for looking at geography, adjacent states or communities with different policies?
So this is one of the things we're thinking about doing. It becomes hard, obviously, because it becomes big. You've got to array things by lots of different additional dimensions. And then you have to figure out a little bit about the interactivity between states. But it actually, given the kinds of talk that are coming out of Washington right now, I think it's going to end up being a very critical thing to do, because the things that are being said are so blind, woefully, I mean, they're so incredibly stupid, as they really require someone to explain that unless you're willing to do what they did in China, which is to have people stand at the border and say, you can't come here, around an area, you can't treat one place different from another place. It's just not going to work. If people see a restaurant's open, they're going to go to it. It doesn't matter if they have to drive 50 miles. So we'll probably end up doing something along those lines. I don't know if we'll do it for the entire United States, or if we'll kind of do just a small number of adjacent regions just to look at that problem. But somebody's got to point out that that's boy, human behavior is such that it's going to drive people to do that. So it's really an important issue.
Yes. And have you done any comparisons for different sizes of population and time after infection when a lockdown starts?
That's what I'm trying to figure out right now. And I've been using data from the United States. And this is actually, as I say, I'm in a discovery phase. So I don't believe in any of these numbers. But what I'm finding really interesting is right now, every time I run the optimizer in this thing, it keeps coming back and telling me that the best quarantine effectiveness assumption, given what's happened, is 0. So every time I run this, it says it's as if there's no quarantine. Now, we don't have very much data. I have very little data in here from after when the quarantine went on, and the numbers from before the quarantine went on are quite small. And so given the nature of squared errors and stuff, I can kind of see where this is going. But if this still, we're long enough after massive changes in behavior that I would have thought things would be manifesting. And right now they're not. So I need to dig in and figure out why. It may be that I can't do this for a country. I really need to do it for a much smaller area to make any sense of it at all. And so that's kind of where I'm at. But I'm calibrating over things like how many days are you asymptomatic? It's coming back with about 1.6 or 1.8. Which is a relatively small number. This one doesn't have a distribution. Actually, this one is pure conveyors. This one is set up.
Bob, I don't want to interrupt, but there's a question in my mind.
Okay.
When you optimize, how do you measure performance?
So this I'm optimizing right now against infections and deaths. So it's just these two things.
Cumulative infections and deaths?
Not cumulative. No, I was optimized against the rate, never optimized against the stock. So this is the new cases per day and the number of deaths per day. And unfortunately, if I run this for a little less long, what day are we on? Run out. So the data is being shown in blue, and it's up to about day 85. So if I just run this model from 0 to 85, probably easier to see what's going on. You can kind of see what's happening. We don't get, in terms of deaths, we don't get that same kind of really crooked curve, which kind of suggests to me that my assumptions on time in the hospital, average length of stay, and onset of criticality in the hospital is too short. So that's one of the things I need to look at. And then this new cases thing, this is going to be really tough because this is all about what we measure and don't measure and how it's measured and how it's reported. And boy, that's just, I mean, we're getting a real hockey stick in the data. We're getting a smooth adjustment, which is what we'd expect. We have a kind of continuous compartment model here. And I think a lot of the hockey stick effect has got much more to do with the way they're actually reporting stuff than anything that's going on in the underlying population. So it's going to be, because of these kinds of things, this is going to be tricky to really sort out to the point where I have any confidence in saying what it's telling us about going forward.
So Bob, hi, this is Jim Hackend. I had a quick question for you. So this is a really very interesting model, and I've been listening in to the pharmaceutical industry and some of the things that they're doing. Right now, they're throwing a lot of their arsenal at all different types of therapeutic approaches to one, help in the short term and potentially help in the long term, because they talk about these multi-bump profiles that they believe is going to happen. They're going to maybe tamp down the rate now, but there'll be a resurgence. This looks, what are your thoughts on how would you bring in sort of, therapeutic approaches, some that are, like vaccines,
So there's kind of three things, therapeutic approaches. One of them is kind of the malaria drug style stuff, anti-viral things, which may have the ability to speed the transit time through an array, through the conveyor, if you will, for some of the people. Chloroquine is obviously been out there, although as everyone says, there's not much clinical data whether it works or not. And then the second one is antibody treatments using plasma, which has been approved now by the FDA. And that would allow people to basically have less severity during the disease progression, as the antibodies from donors would allow the virus to be controlled before their immune system can take control of it. And then finally, vaccines, which are probably a pretty significant way off in terms of time. But they obviously have a huge impact on the infectivity of the disease once you get there. So if it gets to the point where that's the kind of thing we're dealing with, and I hope it does, because that's by far the best scenario, and then we can definitely, we'll have both the time and the reason to expand this model to look at those kinds of things. Right now, I'm so focused on the next 30 days that I don't, I'm not kind of going there as yet, because I'm just very worried that things, you know, the USA is Italy. We're going to just see overwhelmed hospitals and people not being allowed to get in because there's no room for them.
Yeah, no, it's
All right, other questions?
Yes, sorry, I have to go back to, so I think you actually answered this a little with your calibration optimization, but I assume the initial population is for the USA, for which you now have real-time death data. Does it fit?
So as you can see, yeah, as I say, it sort of fits, but that hockey stick kind of behavior you're seeing in the data is not commensurate with what's going to come out of a model like this. And so I'm curious to know if I can make it, or if it really is an artifact of the data. That's going to take some digging. As I say, I'm kind of in what I call discovery mode. You calibrate something, it doesn't fit, now you try and figure out why it doesn't fit. I was hoping to be able to uncover things like the latency time, you know, how long people are asymptomatic and things like that. I don't know if I'll get it. As I say, I'm probably going to end up having to go to much more regional data if I want to get accurate results from this calibration process.
And someone asked, are healthcare workers not tested?
Actually, in the current calibration run, nobody's being tested in here because the testing for the United States has been such a mess that I don't just shudder trying to think about putting it in place. But so right now, there's no one tested in this particular model. In terms of healthcare workers being tested, that hasn't been differentiated from testing in the general population. Probably would make sense to do that a little bit differently. Conceivably, I mean, it just, what happened in Wuhan is so scary, where basically everybody in the hospital came down with it, every worker, like 100%. And so that's definitely something worth looking at.
And someone suggested maybe using New York City data.
Yes, no, I think regional data, and what I'd like to do actually, if I kind of get the time to do it, is use a whole bunch of different regions together at the same time, which would allow me to calibrate sort of population parameters that would be different alongside ones that would be the same, which would actually give me much better results that I have a lot more confidence in if I can do that.
There was a suggestion it'd be interesting to add in constraints, variable system influencers that deal with treatment affecting survival or death rates.
Yeah, so this gets back to the question that James asked on different kinds of interventions that could come into place. And certainly the antivirals, I don't think they're actively being used in the clinical I've heard of so far. So this is one of the things where, unless you've got some clinical basis for making assertions like that, it's kind of dangerous to just put in an intervention and say, oh, this is working, see how much better things would be, because we know that. We just don't know if it will actually work. So I'd like to do that, but I'm not going to do that until I see clinical stuff that's going on and using these things and some results for it.
deaths should have less reporting bias than new cases, no?
Deaths should have less reporting bias. And I'm looking at this thing now. I've been looking at the wrong scale up till now. I just shortened the scale, and I'm saying maybe the conveyor thing is so much more accurate for deaths, and I just have the time too short. Because what's happening is some of these people are in ventilators for 30 days, and I don't have anything like 30 days in my hospital segment right now. It's 6 to 5 or something. And so I think maybe what I need to do is go drag that out a little bit and allow people to be in that system for a longer period of time before it starts manifesting as deaths. And that actually might explain a lot of things. So like this like sudden jump in deaths may have been people who were waiting, who've been eminent deaths that have been prolonged because of the ventilators. And now it's just finally, they've reached the end, and what we're seeing is basically the echo of the onset of the acute condition.
And this is a participant reply to the other participant's question: is still bias if no testing of the corpse or while that person was alive?
Yeah, so I mean, this is like Alzheimer's disease. If somebody dies from, you just assume it was or it wasn't. You open up the brain and then you dig it out. And a lot of these people may not have been tested that way. So there is going to be some stuff that's missed there. Although, yeah, I doubt that they're doing postmortem stuff on people. It's either assumed or not.
Mm-hmm. And another suggestion is there was a town in Italy where all the residents have recovered, and it might be a good source of data if it is accessible.
Yeah, I've been looking for Italian data. It is still a little bit hard. I don't know. I haven't spent enough time, but I've been looking for Italian data, and I would very much like to use that because they're ahead of us in terms of what they've experienced, obviously.
And I also don't know so much about this, but different mutations of this COVID-19.
All right, so there've been sequencing done of the actual virus, and there are 2 dominant sequences that were identified. This is coming out of Wuhan. This is early work. And it's called the L and something else. I can't remember what they are. There is no evidence presented elsewhere that there's been mutation, but other than this very early thing done in China, I haven't seen sequencing work done on the virus. So I don't know what the basis is for people claiming that there's no evidence of mutation. And the Wuhan work was very interesting because they claimed there were 2 very different characterizations of this virus depending on which one it was. And the one that was more dangerous seems to be the one that's non-dominant. So I'm unsure whether or not we have 2 or possibly more strains of the virus running around in the wild right now.
That's just
Hey,
another
Bob, 5-minute warning for your 3 o'clock.
All right.
Thank you. There's this last, 2 more comments, I think. Oh, there are a lot more comments. Okay, hold on. They're just coming in because we have 30-something participants. It's the first time we had this many. So there is variability in the definition of COVID, attributable deaths over time and across places. This may explain part of the discrepancy, perhaps.
Yeah, not only do we not understand this disease, but we don't know how to report it. So definitely, this is why I've been afraid of this all along. There are 2 fears, both of which are real. One of which is of the disease itself, but the other one is of ability to actually say something sensible about it, given how little we seem to understand about it. And so at first I just said, I'm not going to do it because we don't know enough. But at some point I realized other people were doing it anyway, and I'm probably better at some of this modeling than a lot of those people, which is why I jumped into the game.
How do we account for prevalence of pre-existing conditions on COVID-19 mortality? This is dramatically visible in Italian results.
Yes, that is a really interesting question. And in the panic mode that everyone is in right now, I don't know if we're really going to be able to address it in a way that's going to be usable beyond the fact that if you have pre-existing conditions, be really careful, which is very good advice, obviously.
And
longer term, we can actually figure a lot out, but it's going to be over by then, unfortunately.
Timeliness. Okay, so how do you take insights from the model and use them to influence real-world policy response?
This is a really good question. My intended path is to actually reach out to other researchers in the field to try and convince them to change a little bit some of the ways they're thinking about it, especially the epidemiologists. We'll see whether or not that's successful. Don't have a real loud voice here, but hopefully there are enough people jumping about and shouting about reasons. Some of them will get listened to. And I'm hoping to be one of those voices.
So, is it worth doing work on perceived infection rate across stakeholders? The public often may set perceived infection rate as equal to reported infection rate, while experts, by definition, see it as much higher. The public's perceived infection rate seems to impact the contact rate in the SIR model.
Yeah, no, that's definitively true. So that may, I mean, I wanted to put out stuff that would help people understand what was going on in the real world. And that kind of differentiation is something you get that, but obviously not that many people are going to go in and simulate a model relative to the population in the US. So how to reach those people is unfortunately the non-tech voice, which I'm not very good at. All right, so I need to wrap, but thank you for inviting me. I hope everyone was informed, even if this was not enjoyable content. You know, appreciate it. If you have thoughts or stuff, or you want to get copies of any of this stuff, just shoot me an email. I'm happy to send it to you.
Thank you.
Bob, this is a great piece of work, and a beautiful model of a bad thing, but beautiful model.
All right, thank you.
Hey, Christine, could you unmute us also? We can all just give Bob an applause. Would that be okay?
Oh, hold on. I don't know how to unmute everybody at the same time.
Isn't there a thing to do unmute all? Maybe everyone could unmute themselves.
I've never tried it before.
Okay, everybody, on the count of 5, 4, 3, 2, 1.
Thank you, and the recording will be up as soon as possible.
All right, thanks everyone, bye.
Okay.
Thank you.